Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Beatriz Grinsztejn presents a case-based discussion on addressing social determinants as a strategy to support PrEP persistence and engagement for transgender women. Dr. Grinsztejn is the director of the HIV-STI Clinical Research Laboratory in Rio de Janeiro, Brazil, and is the IAS president-elect. For the full online educational program, Staying on Track, Strategies to Support PrEP Persistence and Reengagement, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Grinsztejn has to say.
This is a case that I have recently seen. It is a 22-year-old transgender woman who is using daily oral FTC-TDF for PrEP. And she occasionally missed follow-up visits for HIV testing and reported to us inconsistent PrEP adherence. She also reported substance misuse, particularly of cocaine and crack, occasional transactional sex, homelessness, and having no formal job. It's crucial for us to understand that transgender women are disproportionately burned by HIV infection worldwide, especially in the Americas. Still, many countries do not report healthcare-related data disaggregated by gender. This is really problematic. But a recent meta-analysis identified a 19% HIV prevalence among trans women globally, with a 66% odds of having HIV compared to individuals over 15 years of age. The PrEParadas study was the first trans-specific PrEP demonstration study in Latin America. Overall, 130 trans women were enrolled to receive daily oral TDF-FTC. 85% of those enrolled were retained at week 48 of the study, and increased risk of missed study visits was observed among those aged 18 to 34 and those who reported stimulant use. Regarding PrEP adherence, the measurement of tenofovir diphosphate in dried blood spots was consistent with 4 or more PrEP doses a week in only 49% of the trans women enrolled, with decreased adherence more prevalent among those with lower schooling and of Black race, while there was increased adherence among those on feminizing hormone therapy available at the site. These findings suggest that high PrEP retention is better achieved in PrEP programs that include trans women when implemented in a gender-affirming setting. However, adherence to PrEP over time remains challenging, and societal violence against transgender individuals definitely impacts on the pathway that involves going to a health service, getting a pill, and swallowing it every day. The ImPrEP study was the largest PrEP demonstration study in Latin America, with the goal of evaluating the feasibility of same-day PrEP implementation to men who have sex with men and transgender women in the context of the public health systems of Brazil, Peru, and Mexico. Overall, a total of 9,509 participants were enrolled, of whom 8.4% didn't return after enrollment and first PrEP dispensation. Transgender women, in addition to those younger than 24, less educated, and non-white, had increased odds of early loss of follow-up. So one of the most important barriers for the success of oral PrEP is the need to adhere to an oral medication, taking at least 4 pills per week when we talk about unprotected anal sex. In the ImPrEP study, using the medication possession rate measured, 68% of the participants had a medication possession rate equal or higher than 0.6, which is equivalent to 4 TDF-FTC pills a week. PrEP adherence was lower among transgender women and individuals younger than 24 years of age. Specifically among trans women, Those older than 34 years and those with higher education reported higher adherence to PrEP. While in the overall ImPrEP study, participants had long-term engagement, again, this was lower among participants younger than 24, with less access to education and also among the transgender women. Both transgender women and young individuals had the highest HIV incidence rates in the ImPrEP study. Transgender women often face several barriers to access healthcare and to uptake and adhere to PrEP. For instance, in settings where PrEP is paid, cost is a real issue. In addition, mental health concerns and substance abuse, which are very related to gender violence against transgender individuals, also impact on PrEP adherence. Other individual factors, such as PrEP adverse events and fear of interactions with feminizing hormone therapy, might contribute to difficulties in PrEP uptake and adherence among trans women. And such barriers also involve interpersonal and community factors, such as patient-provider communication, stigma and violence, negative community opinions, and negative experiences in healthcare settings. And also of utmost importance in this discussion that we are having are the structural factors that hinder transgender women to access health services in general, including HIV prevention services such as unemployment, transportation barriers, housing and food insecurity that we very frequently see in our clinical practice. Ultimately, gender violence against transgender women might operate at different levels and contribute to these challenges. Potential drug-drug interactions between feminizing hormone therapies and PrEP can be an additional barrier to PrEP uptake and adherence to trans women. We all know that it's really very important for trans women to guarantee that they are using the feminizing hormone therapy and will get the best benefit from it, because this is critical for them. So far, drug-drug interaction data between feminizing hormone therapy and PrEP is not consensual, with some studies that we will briefly mention showing lower blood plasma tenofovir exposure in the presence of feminizing hormone therapy and lower rectal tissue concentration of tenofovir diphosphate among transgender women. Based on these aspects, there is no safe evidence for us until this moment to prescribe on-demand PrEP for transgender women using feminizing hormone therapy. On the other hand, studies showed no significant impacts of the hormone therapy on TDF-FTC. In addition, it seems that feminizing hormone therapy is not affected by oral TDF-FTC PrEP. Although there is no consensus on whether feminizing hormone therapy may affect oral PrEP, nothing should refrain us clinicians from providing feminizing hormone therapy to transgender women concomitantly to oral PrEP. So it's critical that we can offer feminizing hormone therapy and oral PrEP so that they can realize the benefits from feminizing hormone therapy and be fully protected from HIV acquisition using oral PrEP. Of note, in a large recent study that you certainly have heard about, that is HPTN 083, that is a large study evaluating injectable long-acting cabotegravir for PrEP among MSM and transgender women. And what we saw in this study is that feminizing hormone therapy did not impact cabotegravir long-acting concentration. So this is very important news, and it's very good news for us. We still don't have an answer about the impact that CABLA may have on feminizing hormone therapy, but the information we have so far from other studies, we don't foresee that this is an issue, but further studies are needed to better understand if there is, if any, effects from CAB-LA to feminizing hormone therapies. So when designing interventions to improve the PrEP cascade among transgender women, peer health navigation appears as an interesting strategy. This strategy is based on mechanisms of social cognitive therapy to improve the individual's self-efficacy using socially well-connected community members who support not only HIV care, but also use the strategy to support prevention, provide risk reduction counseling, STI testing and treatment, and facilitate access to mental health services, fostering community building. It also provides an environment of community engagement and building activities. So after this theoretical basis, let's go back to our clinical case that it is about a young transgender woman who occasionally missed her follow-up visits at an HIV prevention services. She also had inconsistent PrEP use and was experiencing major challenges related to housing, employment, and substance misuse. This case is the story of a transgender woman who attended our PrEP services. During her follow-up, she was linked to a government social protection program that included cash transfer and got a job as a community-based harm reduction agent at a local public service. Now, she has a place to live and does not face food nor housing insecurity. She still misses oral PrEP doses sometimes, but substantially improved her retention in the prevention service, where she receives an HIV prevention package that includes risk reduction counseling, regular HIV and STI testing, lubricants, and also counseling on PrEP adherence. Moreover, she was also linked to community health services, rectifying her legal documents, name and gender. And we know that this is something that is crucially important for the transgender populations. And she will be able to access different health services with her social rights assured. She still faces structural violence and discrimination, but joining supportive trans-specific groups and advocating for her rights were important in many ways. And she also adds her voice to the fight for guaranteeing transgender individuals' right to health, including feminizing hormone therapy provision, mental health care, access to surgery if desired, care related to industrial fillers complications, and others. So our key take-home messages are: social vulnerabilities lead to a disproportional burden of HIV infection among trans women. The PrEParadas study found high retention in the prevention services, but low PrEP adherence among transgender women in Brazil. In the ImPrEP study, trans women were found to have increased odds of early loss to follow-up, lower odds of PrEP adherence, lower odds of long-term PrEP engagement, and high HIV incidence. And trans women, as we all know, may face many barriers to PrEP uptake and persistence. Providing feminizing hormone therapy and peer health navigation are strategies that could help trans women to uptake and persist on PrEP. But very importantly, and this is a crucial message we need to understand, is that the lack of these services should never preclude us to provide PrEP to our clients. Tackling social determinants of health is essential to modify the unequal landscape surrounding transgender women globally. Let's talk about social rights rather than only targeted interventions. Well, I hope some of the topics I discussed today reinforce that broad support addressing not only HIV prevention, but also structural factors such as the social and economic aspects is needed to effectively reduce the HIV burden among transgender women. It has been really great to be here with you today. Thank you very much.
Thank you very much to Dr. Grinsztejn, and thank you to our listeners for joining in. To get more from our program, see the link in the show notes. You can view a foundational video module on PrEP persistence, more vlogs featuring specific case examples, clinical thought commentaries from people using PrEP, and downloadable PDF resources for healthcare professionals to print and share. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.